Okay, it started.
All right, great. Thank you. Good morning, everyone. I'm Lisa Emerson. I'm the Senior Health Policy Analyst with the Division of Financial Regulation in the Department of Consumer and Business Services. And welcome to today's Rules Advisory Committee meeting for rulemaking regarding primary care provider assignment rules related to the Senate Bill 1529. Part of that legislation includes that DCBS will conduct rulemaking and adopt rules related to primary care provider assignment and attribution. Let's go over a little bit of housekeeping for reminders about virtual meeting etiquette, that sort of thing. If you could, please keep your microphone muted when you're not speaking. And also, please raise your hand if you'd like to speak, and Karen or I will call on you in the order that hands are raised as best we can. And of course, Karen's going to help me keep track of hands since I will have difficulty seeing hands with my other information on my screen. And I'll go ahead and take the liberty of introducing Karen Winkle. She's the division's rules coordinator and will be supporting me today with this meeting. In a moment, we'll get into introductions of Rules Advisory Committee members. In the essence of time, I'm probably not going to go to the length of having all the different DFR, Division of Financial Regulation staff that are supporting this rulemaking today, nor the interested parties. So if you would please, those folks could put their names, titles in the chat, that would be great, because that'll be a part of the recording. Also, RAC members and DFR staff will have the primary first opportunity to speak during the material review and discussion, which will occur from approximately 10:50 a.m. to 11:30. And if an insurer has a subject matter expert that is a RAC member, but if they have a subject matter expert on the meeting today that they would like to delegate to, kind of their RAC member role for them to speak or comment on anything, that is fine. And again, there'll be a public comment period where interested parties and the public will have an opportunity to comment as well. Let's see. The agenda is on your screen and being displayed. I also emailed that if Karen emailed that information out last week, the agenda, the committee list, and all the meeting materials. These materials will also be posted on the division's active committee work group page, and that's on the DFR website under information for businesses, committee work groups, and then that's where the active RACs are listed. As well, this meeting is being recorded, and that recording will also be posted on that web page as soon as feasible in the days after this RAC meeting. So let's see, without further ado, let's go ahead and get into introductions. And as I go through the RAC committee list, if you just state your name, position, and the organization you represent, that would be great. And if you want to feel free to briefly share what's your top priority or concern associated with this rulemaking. Maybe just be brief, because we'll have to get into the more of a discussion material, and then you can comment at that time as well. Okay, let's start with the committee list and do some introductions. Let's see what we got here. How about we start with Antoinette with Cambia.
Hello, good morning. My name is Antoinette Iwachi, and I'm the Senior Public and Regulatory Affairs Specialist for Cambia. I'm also here with my colleague. He's an interested party, but will be likely talking on my behalf today, as he's a subject matter expert. So when it's his time, he'll introduce himself. Thanks for having us here, and we look forward to the rulemaking.
Thank you. And who's with us today representing Moda Health? I understand Scott White is not available today due to PTO, but he mentioned that someone else might be here today.
Hi. Hi. I'm Bill Dwyer, Director of Analytics at Moda.
conveniently, my team does a lot of the member attribution work that happens at MODA, so I can speak to all of that.
Thank you, Bill. Appreciate you being here. Let's go to Samaritan Health. Do we have Bill Buska today or someone else?
Good morning, Bill Bushka, Director of Government Relations for Samaritan Health Plans.
Thank you. And Pacific Source Health Plans, Rick or Jeanette?
Hi, I'm Jeanette Sims. I'm the Director of Analytics here at Pacific Source and am familiar with our attribution methodologies.
Okay, great. Thank you. And Jennifer Baker with Cigna. Okay, she may not have been able to be here today. Anyone else with Cigna stepping in for Jen? Okay, how about United Healthcare, Melanie?
Good morning, Melanie Anderson, Associate General Counsel with United. We also have a couple SMEs on, and so if they want to provide input later on, then they will introduce themselves. Thank you.
Okay, thank you. And then next, Providence, Bo, or any of the other team that might be here today to represent.
Hi, this is Bo Wrights with,
Go
okay,
for it, Bo.
I'll go first. This is Bo Wrights, policy analyst with Providence Health Plan, and Aaron will be speaking on my behalf today.
Okay, thank you.
Hi there.
Go ahead, Aaron.
I'm Aaron Balls, the Chief Compliance and Risk Officer at Providence Health Plan, and we'll be working to represent the feedback we got from our SMEs back at the ranch. Thank you.
Thank you. And from our provider representatives, do we have Courtney with the Oregon Medical Association? Okay. How about Deborah with Children's Health Alliance?
Good morning. I'm Deborah Rumsey, the Executive Director at the Children's Health Alliance, and work with the pediatric practices in their attribution methodologies and population health activities.
Thank you. Thank you for being here. And Marty Carty with Primary Care Association, Oregon Primary Care Association.
Hi, good morning. Marty Carty. I use he, him pronouns, Director of Government Affairs at the Oregon Primary Care Association, representing Oregon's 34 federally qualified health centers. I'm joined by my colleague, Rob Trachtenberg, who's our Director of Value-Based Pay and is a subject matter expert here.
All right, thank you for being here. And then how about Dr. Tony German with the Oregon Academy of Family Physicians?
Hi, good morning, everybody. Tony German, family doctor, representing Oregon Academy of Family Practitioners this morning. Thank you.
Thank you. And consumer representative Mary Beth with Osberg, are you here today?
Yes, I am. Mary Beth Carino, healthcare advocate with the Oregon State Public Interest Research Group.
Great, thank you for being here. All right, let's see here. So, so now I'd like to begin reviewing the material that I sent out to the RAC members and interested parties. Again, that material is posted on the RAC meetings webpage. If for some reason you don't have that material, well, we're going to display it on the screen here, and then also feel free to email us if you would, if you need copies of that material. What I did was I kind of outlined let's see. Basically, it's a memo, or if you will, from me to on the subject matter of the primary care provider assignment and attribution methodology. And Karen, you've got that up on the screen, I hope here. Let's see. All right, great. So just giving the background as to why we're engaging in rulemaking. Again, like I mentioned earlier, Senate Bill 1529 requires DCBS to adopt the rules prescribing a methodology for insurers offering individual or group health plans to assign and attribute a primary care provider, PCP, to their enrollees if an enrollee does not choose a PCP within 90 days of joining the plan. So basically, we're trying to establish rules that will align with a set of PCP assignment and attribution principles that are recommended by the Primary Care Payment Reform Collaborative in conjunction with the actual recommendations that have been put forth by the value-based payment work group that is doing kind of a subgroup of work for the Primary Care Payment Reform Collaborative. These recommendations are in another document that I titled as an exhibit. That is the actual value-based payment work group's recommendations for value-based payments. And within that, they provide recommendations for patient attribution or primary care provider assignment. So, and I did outline some of that information, those actual recommendations here below in the document. So if you could scroll down a little bit further, Karen. So the exhibit, the attachment B or the exhibit within that VBP work group's recommendations, which is a several page document. It's page 11 that actually has a list of principles. But beyond the principles, when the work group was revisiting the principles, they have come up with actual more specific recommendations about the kind of order of priority for assigning a primary care provider or attributing patient attributions. So point A, or first priority, is prioritizing patient choice. Always ask the patient for a primary care provider of their preferred primary care provider in the enrollment information, even if it's not required by the health plan. So making that a priority. Next, if the patient doesn't choose a primary care provider, the plan will attribute the patient to a provider based upon their utilization, the attribution process, and that is defined in that attachment B I was referring to in the exhibit, which we can look at that here in a moment. Then, next, number 3 or C, if a patient chooses a primary care provider, but then has a predominant utilization with another primary care provider, assign the patient to that provider and communicate to the patient the opportunity to reselect their preferred PCP. And D, if no patient choice and no prior utilization, assign all patients to primary care providers to enable the best opportunity to serve the entire insured population. And then there's one other aspect that was being considered by the value-based payment work group. That is that payers should have a patient correction process and work in partnership with providers to correct inaccurately attributed patients. So those are the kind of the we'll call that the guardrails or the side rails. That is kind of what DFR is kind of proposing, that we set these baseline guidelines, but allow insurers to set up their own business process to accomplish this and not, be as granular or prescriptive in that regard. Thank you for the comments in the chat and taking a look at those. Just one moment. Okay. Well, while we're on this point, why don't we start in the order of the chat of the comments? And I would like to offer the opportunity to Bill Dwyer with MODA to go ahead and speak to D, and then we'll go and move to Aaron Balls with Providence to comment on point C.
Great, thank you.
Yes.
So first of all, I'll just say that we totally support the idea of assigning everybody where possible to a PCP. And PCP assignment in general is required for almost every type of value-based payment mechanism you could think of that's currently being used. So that's, in general, this is a good idea, we think. The one thing that is problematic in this is this point D. So in situations where there's no prior utilization to go off and the member has not expressed a preference, it is problematic for us to try to guess who the PCP is. And just to give you an example, let's say that there's a member that's in a metro area where there are lots of choices, and we don't know, I mean, we know where the person lives, but we don't necessarily know where they work. And when there's lots of options, we're essentially guessing at random if we have to assign everybody. And if there's like 6 choices all around their house, the probability then is 1 in 6 that we happen to guess where they might eventually go. And that's just terrible. And so to put data in there when the vast majority of the time we are going to be wrong is just not good data governance. The other thing with that is if you are assigning a member where the likelihood is that you're going to be wrong, if you have capitation payments paid, then automatically that means that the carrier is going to be double paying. They're going to be paying capitation to somewhere that the member never goes. And then they're going to be paying fee for service to the place that the member actually does go, because you can't deny a fee for service payment when somebody happens to go to somewhere where they're not assigned. And so that's hugely problematic from a data governance and from a cost standpoint. And the last thing I'll just say about this is, if you look at the actual data on who is getting PCP visits, what you end up finding, and other carriers on this call can confirm this, somewhere between 30 and 40% of all members will never have a PCP visit within a couple year period. There are a lot of healthy, relatively younger adults who just, they don't go, nor do they need to. There's pretty limited, if any, medical justification for every member having a PCP visit every year. And so there's a substantial portion of the commercial population that we're just never going to know who their PCP is. They're not going to tell us no matter how much we badger them, and they're not going to go in for a visit. And so we're just not going to be able to know who their PCP is. And I said this was the last thing, but I actually have one more thing to say about this. So, and others on this call can confirm this as well. We currently have a shortage of primary care capacity in Oregon. So we have a substantial number of our primary care providers that have no ability to add to their patient panel. And what this means is, if suddenly we have to attribute thousands of patients to PCPs who do not have the ability to see them, then it dilutes all of the reporting and incentives we have to the patients that they are seeing. And that just is causing a problem. We've already had providers that are reaching out to us with great concerns that suddenly we're going to start holding them accountable for patients that they have no ability to see. And so for all of these reasons, I think that an idea that we should be strongly considering in the rulemaking process is an interpretation of the statute that says, yes, we want to attribute everyone to the extent possible, but leave it at that. Attribute everyone to the extent possible without requiring every single person to be attributed if there's no reasonable justification. And so it's with this point D.
Thank you, Bill.
Yeah.
I appreciate those comments, and maybe we'll circle back to this as we discuss further, but I would like to, and that's really important information to consider. But let's go to Aaron with Providence and let him make a comment as well.
Hi there. First, I'll start out by saying we also agree with the intent of the policy and think that attributing members is helpful to facilitating the growth of value-based care arrangements. My point about C is just that there is tension between what is articulated in A around prioritizing patient choice and what's in C around which seems to say that a carrier should automatically and without reaching out to the patient attribute to a provider other than what the patient selected. We think there's unintended consequences of that, potential for member and patient, surprise. There's interaction with the way benefits work on some plans. And so we would recommend changing C to indicate that, a carrier should reach out to a member if they want to attribute to a provider other than the provider the patient initially selected. Thank you.
Thank you. Okay, I see a hand raised. Mary Beth, you have the floor.
Thanks. I would just echo what Erin just said about communication to the patient, and that being kind of the primary goal of these rules, or at least a primary goal of these rules, to ensure that that communication is happening between the insurer and the patient when these assignments are happening, because it's so important that the patient knows who they should go to and that they have the contact information for the primary care provider, and that they know that their insurance is going to be covering their visits when they go and visit the doctor.
Thank you, Mary Beth. Let's go to Omar with, I believe, Cambia.
Yes, Cambia. Good morning. I'll just say that I would co-sign kind of everything that's been said so far. And one aspect of D that concerns me is that when we have a value-based contract with the provider, it's our responsibility to share who the members are that are attributed to them, including how to communicate with them. So PII information, as well as claims information that should ideally help them manage that member's health. And my concern with D is with that rule, we would potentially be sending PHI and PII data in HIPAA violation to providers who have never seen that patient and who that patient has not told us they have a relationship with. It would be one thing if they selected that provider, but with no way to establish a relationship between the member and the provider, we'd be sharing very sensitive data, and I'm not sure how we'd get around the HIPAA part of that.
Good point. Thank you. Let's go. I see Amy Grant. I'm not sure, Amy, who you're with.
Hi, Amy Grant. I'm a director of commercial medical product with United Healthcare, and I'm tagging along with Melanie Anderson today. So thanks for giving me the opportunity. We agree with others that have been mentioning the concern about C, essentially overriding a patient's selection when they actually tell us who they want to see. However, I think there's opportunity to kind of maybe flip a little bit in terms of taking a member selection as prioritizing patient choice with A. However, there's opportunity if we have claims experience when D comes into play. If there's no patient choice, I think maybe this is just an addition. So if there's no patient choice and prior claim utilization is available, attribute it that way. And then maybe a final E would be if none, then move through like the auto assignment process. But we have the same concerns with overriding a patient choice when they're actually telling us upon enrollment or during a phone call that's who they want to see. Prior history will be available if they've been on the plans before, but members choose to change primary care doctors for a number of reasons, including, oh, I want one closer to my work. So again, just sort of echoing what others have said, but I think there's opportunity to maybe create a fifth point here.
Okay, thank you very much. Let's go to Deborah.
Can you hear me okay?
Yes.
From the provider perspective and trying to operationalize many of the value-based contracts that exist and the growing number that hopefully will exist in the future, I just wanted to address a couple of things of what some of these criteria we're trying to address. And so there may be other or better ways that we could refine the language to address those. I think that D was created to try to identify ways that we don't miss out on providing care to people who need care. Just because they're not utilizing services does not mean that they should not be services. So there is a healthy population that may not need services, but there's also a population that just cannot access those services. And so I think that D is trying to address, how do you identify those that and outreach to those that should be coming in for care but have not? And so so if there's a way to address that, I think that that's where D might come into play. The other issue that D is trying to address is one of those that does relate to value-based care and the timing of assignment. And for those that may not have received care from that plan in the past, but comes in June, and then capitation payments start. How do you make the provider whole for the entire year of services by which those rates are calculated? And so if there's another opportunity to, for those that have not been assigned elsewhere, to be able to make the provider whole in those value-based contracts, again, that's what D is trying to address. So there could be other alternatives in solving for that. And then I think that attribution also is going back and forth between on the incentive side with the quality incentives, that anybody that's in a denominator should be assigned or attributed. And that may be by default what is happening, but if a practice is doing outreach to a patient or communicating via patient portals, but claims don't demonstrate that, there is still in value-based contracts and quality incentives or other incentives, there's still ways that we want to make sure that that relationship is recognized. All of those may come down to patient choice. And again, I think everybody agrees that the patients should be choosing who their primary care provider is. And again, there are ways to ensure that that is emphasized on the health plan side through benefit structure or through, again, having ways that if a provider is outreaching and finding they actually have been assigned to them in the past, but do not want to come to them and they are actively seeing somebody else, some ways for the provider to work with a health plan and to value that communication that has happened to reassign. So all of these are nuances of how to get to C or D in different ways that might be amenable and value patient choice and that relationship with the three-pronged stool of the provider, the patient, and the health plan.
Thank you, Deborah. Appreciate those comments. And I just want to preface before I go on to the other folks that want to speak, that this is our first RAC meeting, and my goal for this meeting was to get acquainted with all of you and get more familiar with this information, not only for myself, but with my colleagues that are going to be assisting me with this whole process. So this is a very collaborative discussion, and I really appreciate all the comments so far. Still wrapping our brains around all this. So it's not always easy to just say A, B, C, and D or E, but we realize that. So let me go next. I can't tell if these are in the order the hands were raised, but Omar, do you still have your hand up? Okay, go ahead.
Sorry, that was a mistake. I meant to put it down.
Okay, how about Bill Dwyer? Are you still wanting to speak?
Yeah, just a couple of quick follow-up points.
Okay.
So, and I put my hand down. So, and regarding C, I think that for the concerns that I've heard about that, just throwing out there an idea, I mean, that potentially could be addressed by just acknowledging that if a patient chooses a PCP, but the utilization does not match that the carrier should take a look at that and use their best judgment based on the data in terms of whether changing it unilaterally is required, notifying the patient, whatever. But I think that that the general concept, everyone would agree that eventually, members are not always going to be super responsive to everything a plan asks them to do, and eventually, if it gets out of whack, something will need to be done, and just acknowledging that, for everyone. Deborah had brought up regarding point B some of the rationale for that, which seems reasonable to me. Requiring every single member to be assigned is a bit of a heavy-handed approach to solving the issues that Deborah brought up, in my opinion. And that also, an idea there could just be if there are people with special needs that should be assigned to a PCP, that the plan do what they can to reach out to those people. So I think the guidance here could be softened a little bit to not have a heavy-handed approach that puts all these requirements on. I just want to give one example of when this has been done in the past and just makes it incredibly difficult for the people, the operational people at health plans to deal with some of these requirements. One of them is the idea that you should certain types of providers should be allowable to be PCPs. OBGYNs and naturopaths and some of those people, and putting all of these requirements creates a tremendous amount of confusion and uncertainty in the carrier trying to figure out who is actually the PCP when a member sees multiple providers. And so I use this as an example. I mean, we have specialty clinics in Oregon that have said, you know what, we're a specialty clinic and we focus on women's health care, where they're not doing primary care, and yet they're certified as a PCPCH, and we're required to have the member be able to choose them, even though they'll admit we're not even doing that primary care work, and it's just some of the overly prescriptive requirements, although they're well intentioned and everybody here is trying to do the right thing, they're just causing they cause downstream problems. And so my general suggestion is that we all agree that we should have this member attribution. We should do it as much as we can, but let's not be overly prescriptive or heavy-handed and allow more flexibility in the way these rules are written so that we're not having to do things that are counterproductive.
Thank you, Bill. Let's go to if Dr. German, did you want to make a comment?
Yeah, great. Sorry. Thank you. And coming from a lens of Oregon County family practitioners and primary care and with interest in both these issues, C and D, I think bringing clarity to, the locations of practices that are able to support the efforts in value-based care. And really, I think Mr. Dwyer outlines that there's some discrepancy with that. So, highlighting how we bring a focus and lens to those practices that are able to support the intended interests of preventative health and primary care and the return on investment that does for patients' outcomes, as well as just reducing costs to the system. So I don't know how that comes about, but it is interesting to find a listed practice that is specialty care that isn't robust in the team-based approach that we're trying to accomplish with the medical homes. So I think that's something maybe to look out and outline if possible. The intentions of D, I think, are really well outlined, Ms. Rumsey. We would support, that practices are assigned in patients in the interest that we know that, most patients in some cohorts that are of younger demographics are not going to need that utility, but we don't necessarily know that. So an interest that as we move in the state to value-based care, we get the return on that when people are assigned to that. I understand the concerns of lack of access for primary care in the state and across the nation, but that doesn't mean we shouldn't continue to do that. I think the language is something that can be worked with and would support that. However, I think we really need to kind of outline that if a patient isn't assigned, but then gets seen by a clinic, but then has more severe consequences or outcomes with their health, which perhaps could have been navigated by having them assigned in some of those preventative interventions that we can do. I think there's value in us maintaining the integrity of the intentions of D. So thank you.
Thank you. All this, appreciate your information. All this is great information and will greatly assist us as we further contemplate all this. So I want to offer more opportunity to RAC members to, have that opportunity to comment. Or if we want to go ahead and open it up to the larger group of interested parties, happy to do that too. But again, I just want to continue to glean as much information from you all as subject matter experts in this area for us to be able to consider. So is there anyone else that hasn't had an opportunity to speak with the RAC, as far as RAC members, that would like to make any further comments? Melanie, you have the floor.
Hi, kind of on a different subject, but related, about the notice requirements. So I would be interested to hear, especially from the provider group, you know, when we assign, if we do have to assign, if the member doesn't assign a PCP and we provide notice to the member and the PCP, you know, we're trying to figure out the best way to notify providers. And, you know, in one, I'd like to know how prescriptive the DFR is going to get in what that notice looks like, either on the member side or the PCP side. And if providers, you know, we don't want to be sending tons of mail. Obviously, I don't think providers would love that. But, you know, what would be kind of the preferred method that they would like to get that communication?
Thank you. I'd like to offer an opportunity to the provider audience to comment on that, or even if Mary Beth Osberg has a comment. At this point, we don't know how prescriptive we may or may not be. Initially, the plan was not to be as prescriptive in the real detailed business practices that each of you may have to undertake to meet the requirements. So, but all this needs to be, we need to take this information back and discuss it further. So, but I see Deborah's hand is up.
Yeah, I think that one of the best mail is not, anything on paper is not desired from the provider community, but I think some of the best notification methods have been, one, for those practices that are able to receive it, an electronic exchange of the rosters with the contact information to enable outreach and establish that patient with a practice. And if that's not available, many of our health plan partners have portals that have those rosters with that same information available to the provider groups. And so that might be also another way to be able to notify of those rosters. I mean, of those patient choices. And then identifying, you know, the enrollment, like the start, and if there's a stop period, the product that they're, and then how they were assigned to them. Is it a patient choice, assignment, attribution? All of that is helpful information as the provider is outreaching, so that they know if it's a known selection or if they're reaching to somebody who may or may not know that they have been assigned to that provider. Those are ideas. I don't think they should be in rules, but those are ideas.
Thank you for those ideas. We welcome other ideas. So let's go though to Dr. German again.
Yeah, just to add on that, I think the electronic portals have been really helpful. Also, just points of contact, you know, identification among the plans. We've had really good facilitation with the CCOs locally, and having that point of contact with somebody and updated lists and outreach with that has been an effective strategy.
Thank you. Does anyone else have, with the RAC, have any suggestions on best practices for communication in this regard to patients? Okay. Well, why don't we just take a moment to pull up, Karen, the other material in attachment B within the VBP, the value-based payment models recommendations. So that'd be on page 11. And these are more, as I understand it, they are more of the principles that were developed by the work group in 2018. And again, these were revisited. And that is when the VBP work group just came up with those more specific, you know, A through D and possible E. But I just want to make sure you connected the dots on why I provided this information to the RAC and interested parties. So this information. Let's see.
Thank you. I think that the payers that I've been talking to agree on the, again, it's the patient choice and the patient selection of PCP, which is very important as the primary method for the assignment. And one of the things that has been discussed in our circles with the, other providers is as opportunities, not to be put in rules, but again, the acknowledgement that the patient also needs to understand their role. So emphasizing that patient choice piece. When they select a PCP, that they do have an obligation to go to that PCP for their services and to I guess respond to care, if you will, and that can be done through benefit design to encourage the patient to see the provider and perhaps as benefits play through with a three-legged stool to also ensure that going outside of that might result in perhaps a higher copay or something else, but finding creative ways to bring the patient into that patient choice, I think will be very helpful as we move towards the value-based contracts, which is why I think that these rules have been put forward. So I don't want that to be lost. I don't think it should be in the rules, but understanding and acknowledging that should be a part of this discussion.
Thank you. Very good information. Well, we are a little ahead of schedule, and I can tell we're kind of hitting a pause moment here, but give an opportunity for other people to raise their hand on the RAC. I see Aaron's hand is raised. Aaron with Providence.
Hello again.
Hi.
One of the things is down at the bottom. It talks about clinical or clinic versus practitioner assignment, and it seems to be set up as an either or. And in our experience, it would be best if that were set up to where clinics could be assigned, because some clinics operate under that model, or individual providers could be assigned, and it's not an either or choice. The other piece, I guess, is just that we are seeking, we need to take a closer look at the law, frankly, and see to the extent to which this is already prescribed, but clarity around whether and which specialists could be assigned as PCPs, as opposed to like family practitioners and other traditional PCP folks. Thank you.
Thank you, Aaron. Yeah, we've been we received that question, and we're still contemplating that aspect about which providers. Yeah, a lot of issues to consider here. Let's see. Anybody else from the RAC, DFR staff have any questions they'd like to pose, comments? Bill with MODA.
Yeah, I think that the issue that that was just brought up about individual versus clinic level assignment, I think that is absolutely needs to be addressed in the rules. And the reason it needs to be addressed is that if you read the language of the statute, it is ambiguous on that point. But if somebody who did not know anything about member attribution were to read it and see the definition of primary care that exists in there, they might draw the conclusion that you have to assign everyone to an individual. And I think that in terms of the primary care payment reform collaborative and probably the people in this group, I think there would be general agreement that in most cases a clinical assignment is better because of the turnover that happens among individual practitioners. It just creates a lot of headaches. And again, this might be an example of, best intentions. Yeah, it would be great to assign everybody to an individual. The reality is that it's just not, it's a great idea, but when you meet the reality of how you would actually do it, it's not helpful. And it would not be helpful to have everyone assigned to an individual. And so because of the ambiguity there, and because of, I think, the general agreement that clinic level assignment is often a better solution, I think we should take a position in the rules just to clarify that clinic level assignment is okay, and it does not have to be at the individual level.
Thank you for emphasizing that point. Okay. Let's see, we got any other information in the chat. Okay, thank you for that chat, Deborah. If I pause long enough, I get some more hands raised. I like that. Okay, you have the floor, Deborah.
Thank you. I'm trying to see if it's, I know was discussed before. I wanted to emphasize the correction process and to think through on both sides, the health plan side as well as the provider side, when a different provider assignment might be found. And so either through utilization, like we had discussed as one of the points, or through provider outreach to a patient. It is very often that when, and this happens with the OHP population when they are just assigned and the patient may or may not know what PCP they were assigned to, a practice might outreach to that patient and they say, no, I don't want to go to see you. I'm already established with this practice at a different location. And so I think that correction process, or having that liaison and a method for providers to reach out to the health plan will be an important part of this rule, just because it's inevitable that assignments will be done wrong. And so making sure that there is that process and method to be able to make those corrections. And if the provider is already outreaching to the patient, I think we need to discuss whether or not that's sufficient, because they have made that contact. It just hadn't been with the health plan as a way to correct those assignments. So I think that might address some of the concerns with B or C, or, above, that we can refine the language so it can be amenable to the health plans as well as to the providers in getting that provider assignment correct.
Thank you. Let's see. Let's go to hands raised. Let's go to Jeanette Sims.
Hi, I'm Jeanette Sims from Pacific Source, and I apologize. I'm acting as a subject matter expert, so I haven't been as involved in the previous work here. I was curious if we've had any employer representation in the rules around this, since they are purchasers of healthcare, and they frequently purchase plans that don't require these types of assignments. I was just curious what involvement we've had, or where they've kind of been in the conversation around this, if that's helpful.
That's a great question. I know that we are, in consultation with kind of starting the conversation a little bit with large purchasers of healthcare, which is PEB, Public Employees Benefit Board, and Oregon Educators Benefit Board, because they're fully insured plans we understand would fall under these rules for fully insured, because the division doesn't regulate the self-insured employer group plans. So I would have to probably take that question back, or if some of our other state colleagues that are on this call today might want to speak to that were involved with the primary care payment reform group, value-based payment group, to speak to that employer involvement question. I don't have that information right now.
Part of the reason for my question too is that obviously these kind of regulations require additional infrastructure and cost associated with them to support them. The process the payment correction process, the process to ask members and follow up with them, and regularly, because some, at enrollment, you might have somebody covered for multiple years. They've made a change. And they haven't been seen regularly, so they're not hitting a claims-based algorithm. There just might be situations where, there would be additional infrastructure on the provider side and health plan side required to support the administration of these these rules, and it could result in additional costs that might need to be associated with that. I was just curious how they were involved.
Yeah, I don't, I'll have to, again, take that question back and think about that. And but the insurers, you know, who are providing the group coverage to these employers, I wonder if they would, if anyone with the other insurers would care to comment on this, on Jeanette's question of what they would see as potential infrastructure or costs that might be put on employers. If not, please think about it, and I definitely there'll be an opportunity for if you could follow up we'd so appreciate if you want to follow up any verbal comments you give today and written comments. Those would be needed in the next couple of weeks. But yeah, I'll have to kind of take that question back and think more about that, and maybe reach out to some of our employer contacts. We're getting to the point where not seeing any hands really raised from RAC members, so I think I'd like to go ahead and have Karen, could you go back to the first document where it had the kind of proposed framework or side rails, or, you know, kind of baseline things we were considering for the rules, in case people have have questions or want to read that material on the discussion. The discussion document.
Okay.
Yeah. Yeah, that right there.
All right.
Let's go ahead and open it up right now for comments from interested parties or the public who may be aware of this meeting and online. You can give some time for that. All right. Well, hearing none, no hands raised. I think that there's been a lot of great discussion here on the, you know, initial discussion. I'll need to go back to the notes, transcript, and really capture everything, all the issues. And I'm happy to kind of share those notes if helpful to the RAC members, so you can kind of piece it all together and think about it. And then so we'll be having a second RAC meeting on the 25th of July. I thought we might be ready to come back to that meeting with draft rules. I can't make a promise that that's going to be the case, just based on what the dialogue that has gone on here today. So have a lot to take back and think about. I did give you a draft. It's kind of our draft template of our statement of need and fiscal impact. It's always helpful if RAC members will take an opportunity to review that document. Just the questions being posed, especially with respect to how these adoption of rules in this regard to PCP assignment may impact racial equity and equity among other underrepresented groups, or that could be potentially impacted. That's helpful for our division to receive your insights about that, you know, how it's going to impact a group of people differently than others. And of course, you know, like Jeanette raised the issue about potential impact to businesses or employers and potentially small business. So that's another important question. If you have insights with respect to that, it's helpful to know as well. And of course, I'll be drafting a lot more, you know, information, you know, initial information that I'll send to the RAC as well for review once it's more fully filled out. So that's something for the RAC members to kind of put on their future to-do list. And then I want to, again, give it another opportunity for anybody, any folks to comment. But I'll just keep kind of talking and going through the agenda. Okay, Bill, you have the floor.
Yeah, I'll make this quick since I made this point again. So
yeah.
I mentioned that that we're strongly opposed to that point D that requires everybody to be assigned, and I raised a number of comments. There are a few people that made comments in support of D. But I have yet to hear somebody directly address the point that although we agree it's a great idea to attribute somebody, the reality is that more than 30% of commercial members will never have a PCP visit. And if we try to do that, we're going to be wrong. Okay, if we try to guess, in the majority of cases, we're going to be wrong. And it leads to clinics complaining that there's members assigned to them or whatever. If we would like to move forward with a policy that requires us to do this, I think it is incumbent upon the supporters of point B to explain why they think it's a benefit to to guess when you're going to be wrong most of the time, and what would be done about that.
Okay, does anybody care to comment or respond to that question?
Amy
Hi,
Grant with
this is-
United Healthcare. Sorry, go ahead.
Go ahead, Amy.
Okay.
Oh, I was just going to say, I would agree. You know, I think most health plans have gone through plans where we have PCP required plans, so we go through that self-selection. But to the point before, it is a guess, and the likelihood are we going to land the pin on the right spot on the dartboard is highly improbable. You know, I don't know if there's opportunity there to open this up to say members have every right to self-select a primary care physician, and perhaps even go as far as we can say we have utilization, therefore we have a logical selection to assign a primary care physician if one has been utilized. If there is no patient choice and no prior utilization, it is likely going to possibly even cause confusion from a member to think, now all of a sudden I have to go to this primary care, or primary care's misunderstanding legislation to say, okay, you're not assigned to me, so therefore I can't see you. So I think having a PCP identified when we don't really know who that is actually a really good point, and should be considered.
Thank you. And who else had their hand raised, or if you could use a hand raise function, that would help me keep control of things. Okay, Marty Carty, please.
Thanks.
You have the floor.
Marty Carty again on behalf of the Oregon Primary Care Association. I'm going to harken back to the Universal Access to Primary Care Work Group, was where some of this originates, and just remind folks that really, you know, the intention of the work group and the report that came out of that was really focused on ensuring folks get access or know that they have access, and that we're wrapping arms around people who may otherwise not access care. And so while, you know, I think the spirit of D and some of these others that folks have concern around, maybe we need to do some work on the language. But I certainly, when I go back and I look at the report that the work group issued, I'm reminded that I think we need to stick with it at a minimum, the spirit of the work group's intention. And that was to ensure that people are not only aware of that they have access to a provider, to a clinic, and to primary care, but also that we are encouraging and wrapping arms around folks and getting them into care, because that's what drives down costs. That's what improves outcomes. And so to simply discard this as not workable, I think is not an option from our perspective. Instead, I think we need to think about alternative language. How do we make this language that we have in front of us today better, so that we can stick with the spirit of what the work group intended, that we can ensure that patients are connected to care, we don't overburden providers, and also that carriers, you know, aren't, as I think someone mentioned, aren't double paying, and we don't create a hardship on the carrier as well. I think there's probably, over the course of this work group, a nexus for all of those things. We can find some alignment, but I have to strongly say, as a member of the work group that authored that report, I cannot support moving forward with just discarding that as not workable. Thank you.
Thank you for those comments, Marty. So I'm going to go in the order of the hands raised list here. So Deborah, you have the floor.
Thank you. I am in agreement with Marty, and this may not be the appropriate language, or maybe the best way to approach the problem that's trying to be solved. And I really appreciate Marty bringing us back to what the work group's intention was. And I think that there's two items that this is trying to solve, and there may be a better way to do it. Number one is exactly what Marty said, which was wrapping their arms around people that aren't accessing services, but could benefit from that access to services. So how can we address that? And that also hits the point of what you had showed in terms of how does this impact different populations. And so if we think about how we're impacting the underutilized or those that cannot access services, how do we address that in a different way? And then number two was on the provider side, on the financial side. Again, D may or may not be the right way to do that, but how do you make a provider whole when a patient who has not previously utilized services comes into the office to access services in the middle part of the year? So how do we go back and make them whole if they are on a value-based payment that's capitated, for example, and they need a full years of service? It could be that there's a mechanism to do retro payments back to the beginning of the year or to help make the provider whole financially. So there's two. I feel like those are two of the issues it's trying to solve, and there could be different ways to solve them in the spirit of the original intent.
Thank you, Deborah. Let's go to Antonio.
Yeah, I just really appreciate the prior two comments and just the support, from Oregon family practitioners feel that D feel fairly strongly that having the intentionality of this and the work groups and moving the state forward, that we do feel that this prioritize better health outcomes for our communities and for our patients. And feel that, dismissing this would be unacceptable, and feeling that we really, as we're moving with value-based payments, this is hard, this is challenging. However, the intentionality I think needs to be maintained with this. So just appreciate us continuing to refine the language surrounding this rulemaking process with D, however, still having the intentionality of it.
Thank you. And then Aaron.
Yeah, thank you, Aaron from Providence. I think it's just helpful context, taking a step back to think about the fact that this rule does not regulate the actual value-based care arrangements that may or may not exist between providers and payers. It's really about requiring that assignment. The implications of that assignment are still subject to the benefit plan, the negotiation between the provider and the payer around reimbursement and what that structure looks like. So, as we think about D and what it means to assign a member who may not have experience, it's important to remember that it's narrow to the assignment. It doesn't necessarily, absent other agreement between the provider and the payer, have implications for payment. That's worked out separately and not as part of these rules.
Thank you, Aaron. It's a good point to emphasize. Let's go. Oh, sorry. Omar, you have the floor. I was muted.
So this is Omar on behalf of Cambia, and I guess question to Aaron. So if is the requirement just to assign members and then take no subsequent action? Because if there is any subsequent action, which I think we have to notify the providers, I think that's part of this legislation. Then I don't think it's as impactless or as separate from the outcomes of that assignment. While the financial part of it might be still amenable, if there's any sort of subsequent action, then there is an impact. And if there isn't any subsequent action, then sure, we might be assigning members to providers, but that's the tree falling in the forest that no one's there to hear, right?
Well, from the carrier perspective, that may be the case, but I'm hearing our provider friends say that they'd like the opportunity to reach out to these members and try to get them into the clinic and establish care if they need it. So I think it's just kind of a fact looking at the law that it doesn't attempt to regulate the substance of the VBC relationship. And it, depending on what these rules require by way of, communication of information, there are subsequent steps that need to be taken as far as communication between the plan and the provider. My point was just that it's not automatic by virtue of this rule and any assignment that occurs under D, if that's adopted, that there will be a capitation payment that follows.
Thank you, Aaron. And let's go to Marty. You have the floor.
Thanks. I would echo Aaron here. I think the intention, again, of the work group was not really to force a payment. I think, those we left, the work group left open for the provider and the carrier negotiation. I think the goal here, again, was, as Aaron really stated very clearly and very well, was to ensure that providers know who those folks are and have an opportunity to reach out to folks and bring them into care. If then that person accesses care, perhaps then contracts or some other arrangement says, sure, then we'll start a capitation. Maybe we'll retro capitation. Some other, I think, again, we're really open to what works, but we want to make sure that people have some kind of connection to care, and then the providers, particularly in the safety net space, have the ability to reach out to those folks and bring them into care. We do that every day. FQHCs do that every day for their Medicaid enrollees. We want to make sure that that extends to the other folks that seek care or could be assigned to an FQHC, because the model really is bringing people in and connecting them to all of the services that they need. And if we don't have that opportunity by assignment, either at the provider level or the clinic level or some other assignment mechanism, again, we're not stuck on any particular thing, then we lose people and we lose an opportunity to improve outcomes, to drive down cost, and so many of the other things that are wrapped up in that. So thanks, Aaron, for your comments.
Thank you both. A lot of great, like I said, a lot of great information exchange today. Gonna need to take some time to process it all, but this is very helpful for the division. Please feel free to continue to put comments in the chat. This is being recorded, so you can get a copy of the recording. It will be posted on the division's rulemaking webpage for the active committees, rulemaking committees. To repeat my request, it would be helpful if for the kind of the key message points that have been made today that are like priorities for any of you, any RAC members, any interested parties, please put those in writing in the written comments. And if you can, we'd like those by next Friday, the 21st. However, if you need additional time, just reach out to me individually. Because again, this probably isn't going to be a process wrapped up within 2 RAC meetings. That's pretty apparent to me right now. So, but again, great information. This is what we needed to get started. Appreciate the time today. The next steps, again, like I mentioned, comments are requested to be received by next Friday. And then we'll have our next RAC meeting on Tuesday, July 25th. Still going to have to kind of process on what I can, if anything, can be brought back to the group, but if anything, it might be organizing all these talking points, all the information that's been shared today. I can't promise that there'll be draft rules, but there'll be an attempt to get progress going on that, because I know insurers specifically are, as our providers, but the insurers for their policy forms and things are eager to get that going and getting it ready to be in place for the 2024 plan year. Last last opportunity for anybody that would like to have a word. Otherwise, I might want to give you the time back today. Okay, we have somebody raise their hand. Antoinette.
Yes, hi, this is Antoinette again from Cambia. Just so I understand the next steps going forward with respect to actually drafting the rules. So am I hearing that once you receive any written comments and after our next RAC meeting, July 25th, we may have something in our hands to review at that point? And do we provide comments then electronically? And then the DFR, I guess, is there another opportunity for us to get together after the next RAC meeting and after the draft rules roll out to discuss what's been drafted?
Yeah, I think that's important to do that. So that would definitely be my priority anyway, that we would come back together after the 25th. Keep this process going and to kind of get something written down in terms of draft rules. Because again, we were wanting to take an approach of more the rules being not super prescriptive, but definitely having guardrails and side rails. And then the insurers and providers administrative processes that they normally engage in, you would need to consider those rules, but you would have your own process of those discussions, negotiations. But yes, I think we should be able to bring back some draft rules after the 25th and discuss those again as a group for RAC members and interested parties.
Great, thank you.
You're welcome. Anyone else?
Do you have Bill?
Hey,
Has his
Bill?
hand up.
Okay, Bill.
Yeah. Eventually I'll run out of things to say.
Please don't.
And just wanted to address, so there was some discussion earlier about what the impact might be on VBPs. And the comment was made that, the legislation does not call out VBPs at all and makes no requirement. And so this is a great example of, yes, that all of that is true. However, it's also true that carriers have generally will have one place where member attribution data is stored, and it just would not be practical to say, oh, this group of member attributions is going to be paid under a VBP and this other group isn't. And it's just, this is an example of, you need to understand how these carrier systems work. And just because the statute doesn't specifically say it's going to impact a VBP, it doesn't mean it won't. It absolutely will impact all of the VBPs that carriers already have. I just don't think that you can point to the law saying it doesn't mention that and say that there will be no impact. It just is not right.
Thank you for that comment. Anybody want to add to that or respond? Okay. See, if I pause long enough, someone puts their hand up, so that's good. Jeanette.
I was just gonna align with what Bill said as far as how, our systems work. We use these in these areas of assignment and attribution in our existing VBP arrangements. And our systems aren't currently designed to sort of have different structures for different arrangements, different assignments for different arrangements, if that makes sense. So how we administer PCP attribution would directly impact all of the related arrangements that we have as well. Just wanted to confirm that that's true for Pacific Source as well.
Thank you. Marty, you have your hand up?
Yeah, and I think, again, from the Primary Care Association's perspective, we are extremely sensitive. We certainly don't want to, and I don't think the intention of either the work group or the legislation that passed was to blow up any systems. And at the same time, I think there was as I'm remembering, there was an undercurrent or a intentionality that the system as it is today doesn't work for people, and we're missing opportunities to connect folks to care. And if we are encouraging people to access care by either assigning them or additional outreach, or again, whatever that looks like, I want to be really clear. We are not stuck on one particular model or the language in this document that's on the screen today. But again, perhaps the system, because the system's not working for people, it does need to change. And what that looks like, I think that's an opportunity for us during this RAC to figure out going forward. But perhaps we do need to see some changes. And that was the intention of the work group, to make changes to the existing system, because it was clearly not working for bringing people into care, connecting people to care. And so we need to find a pathway that works for carriers, that works for providers, and that works for the patient. And so I just want to follow up the previous comments from that. Thanks.
Thank you. Okay. Anybody else? All right. I think you're going to get about 10, 12 minutes back in your day. Once again, thank you. Thank you. So appreciate you being here today and participating in this RAC. It's very valuable information and just really helpful to the division as we try to wrestle with these roles. So to support, primary care. Reach out to me if you have any questions. I'm available by phone or by email, and look for that recording, out on the RAC website. Hope to see you all at the next meeting, and don't hesitate to ask any questions. So thank you again for your time today.
Thank you.
Thank you.
Thank you.
Thanks, everyone.